name is Casey Abelin Stevens, and I'm an assistant professor of speech communication at College of DuPage. Thank you for attending Housing is Healthcare, where we will examine the mental, physical, and emotional benefits of proper shelter. I am pleased to welcome you to the conversation featuring Jordan Holliday, social media specialist and content writer at College of DuPage and housing security advocate, April Rudzik, president and CEO of DuPage PADS, whose mission to end homelessness in DuPage County has become critical to the health and well-being of our community. Emily Basham, licensed architect, COD alumna, and member of the COD architecture faculty. And Dr. Aaron Robert Corals, emergency medicine physician at Northwestern Medicine and an instructor of emergency medicine at the Northwestern University Feinberg School of Medicine. This presentation is provided in partnership with Addison Public Library, Bellwood Public Library, DuPage PADS, Glenside Public Library District, Northwestern Medicine, and Wheaton Public Library. Before we begin, I just have a few housekeeping notes. All participants are muted with videos off. Please submit questions in the Q&A box. Our panelists will take questions at the end of their discussion. The participant chat is open, but won't really be moderated. The presentation is being recorded and will be archived for future viewing on the college's website at www.cod.edu/experts and the COD YouTube channel. What does it feel like to be without a home? Through the eyes of a child, it can be confusing and frightening. College of DuPage employee Jordan Holliday has a personal affinity for a local nonprofit organization called Bridge Communities, as it was a saving grace during his own experience with homelessness as a child. He has since spent years proudly advocating for housing security for families through volunteer work with Bridge Communities. This is Jordan's story.
I believe I was 11 years old at the time, and I was in the 6th grade. My family and I, we had just been evicted from our apartment. So we spent a couple of months pretty much going back and forth between different friends' homes, family members' homes, hotels. There was one point where my mom, my brother, and I, we even slept out of our car a couple of nights. And somehow my mom got connected with someone who was familiar with the Bridge program. And before you know it, in the next couple of months, we found ourselves being moved into an apartment complex in Glendale Heights. But those months leading up to it, very uncertain times. So as an 11, 12-year-old kid, scary to say the least. Not sure of what the next day was gonna bring, not sure of pretty much anything. So Bridge for us came at the perfect time.
Please join me in welcoming Jordan Holliday.
Hey everyone, and thanks for joining us this evening. As you just heard briefly from the video that I did with Bridge Communities, I experienced homelessness as a preteen in DuPage County. And my purpose for speaking to you guys this evening is to talk about the health impact, and specifically the mental health impact that homelessness had on me as a child at that point, but also the impact that I know from advocating and for interacting with children experiencing homelessness today that it continues to have. So I'm just going to talk briefly about the mental health struggles that I dealt with and what I still see today. So as I mentioned in the video, I was about maybe 11 or 12 years old when my family and we found ourselves homeless. And what I remember from that time was that it impacted my mental health in a variety of ways. But the main two was, number one, the uncertainty of just not knowing where you're going to sleep tonight, not even knowing if, your family is going to be able to remain together. I know that was a huge concern that we had, but also the second way that it impacted my mental health was just that immediate loss, an abrupt loss of any sort of like social life. I had friendships at that time. Like I said, I was in the 6th grade. So I had plenty of friendships that I wanted to maintain at that time, but I just couldn't. I couldn't invite my friends over for video games anymore or for pizza night anymore. All of these things that the typical 11 or 12-year-old kid is accustomed to, out of nowhere, that was just not a possibility for me or my brother, who was just 2 years older than me at the time. And that's why I've spent much of my time in my interaction with bridge communities advocating for better mental health resources for children experiencing homelessness. So, long story short, we ended up being connected through Bridge. My mom coincidentally had a dental appointment. Speaking of healthcare, had a dental appointment one day where the woman working the front desk was able to connect her with Bridge Communities, and that's how we ended up becoming involved with Bridge. And before you know it, maybe about a month or two later, like I mentioned in the video, we found ourselves in Bridge Communities, which, long story short, is a transitional housing program. So they provided us with no cost housing for 2 years. And during those 2 years, they also were able to provide my mom, my brother, and I with a variety of resources. For me as a kid, they were able to provide me with, tutoring resources, because one way that it impacted me, I was having so much trouble coping with, like I said, those mental health struggles, and just all of these struggles that go along with being homeless. So I was struggling in school, both from a grade and study standpoint, but also a behavior standpoint. I began to get in trouble in school, which at that point in my life, I had never been in trouble. It was such a rarity for me up until that point. But it became so common because I just didn't have any, coping mechanisms. So once I got into the Bridge organization, they were able to supply me, like I said, with tutoring, but also like mental health resources to help me cope with what I was experiencing. And I can say that was just as important as having a roof over my head. And that's when I realized that housing is healthcare, seriously. And I'm interested in learning more from Aaron, April, and Emily about, not only the mental health tie-in between housing security and healthcare, but also, the physical health ramifications. So I'm interested to learn more, just like all of the attendees out there. But that's pretty much my story. Yeah, I'm looking to learn more tonight.
Thank you so much for sharing that with us, Jordan. We'll get to hear from you again at the end of the panel discussion. Jordan's experience mirrors that of many families in DuPage County. April Rudzik has led DuPage PADS through this unprecedented time and is here to tell us about the important work her staff members do every day to address the increased basic needs of our neighbors.
Hi, good evening. I'm April Rudzik. As Casey mentioned, I'm president and CEO of DuPage PADS, and just really grateful to be here with College of DuPage to talk about this very important and relevant topic right now. Also very grateful to Jordan for sharing his story. We had, at our high point, 89 children in our hotel-based shelter this winter. And it was very difficult on them. But I'm happy to say we just had a placement at Bridge. They are a partner of ours. We're very proud to partner with them. And a mother and her 7-year-old son last week just graduated out of our emergency shelter program and into Bridge's transitional program. So excited as we share collective victories and see more people graduate out of programs and into a better life. So I'm talking to you this evening about housing is healthcare. I want to begin with just reiterating DuPage's mission, because that's why I'm here. It is to end homelessness in DuPage County, which brings me to our question for the evening. Does in fact housing equal healthcare? Here are some facts, and you can decide for yourself whether what we're saying is relevant. I would argue yes, and here's my why. So some facts about health for people experiencing homelessness right now. When you have, for example, the flu or bronchitis, having a place to stay during the day where you can safely sleep or rest means you have an opportunity to heal. If you don't know where you're sleeping, if you don't have a bed, if you don't have a place where you are safe and can rest, it's very difficult for you to get better. Also, Every once in a while, if you are unsheltered or in a congregate shelter, it is very easy to lose or forget your medication because you don't have much of a place to store it. Our friends who host congregate shelter, and now as we're in hotel-based shelter, there is a place for you to do it. But if you are literally living without a home of any sort, it's difficult to keep your medication in place. There are also refrigeration issues often with medications, and that can be an issue when you are homeless. If, for example, if you're diabetic and need insulin, you need a fridge. And people come in and they are literally unsheltered. Another issue that is often the case are skin issues. They're very common, things like scabies or open wounds, because again, you don't have shelter to keep things clean. And that without your ability to keep your skin clean, it can be a real challenge. Some more facts that I think are important for you to know. So some more facts, again, that I think are important for you to know. When we do street outreach work at DuPage Pads, people who are unsheltered and are living in their cars very often have circulation issues because they cannot get up within a enclosed space and move around. So if there's weather, it's very difficult for them to get good blood circulation. This can be a problem. People experiencing homelessness are also 12 times more likely to have dental issues. It is very difficult to brush your teeth if you don't have running water and you don't have a sink. The most often seen dental issues at pads are missing teeth or tooth or gum infections. And if you have a latent tooth infection, it's also can lead to things like heart disease, and as well as making it difficult to chew foods. Also, without a kitchen, which means no fridge, stove, or pantry, nutrition can also be very challenging, especially fresh fruit and vegetables. Current nutrition and effects of many years of bad nutrition can cause health issues of all kinds. Also, I would like to share with you some things we've noticed specifically during the pandemic. It is not possible to shelter in place and isolate in place when you don't have a place to stay. When we were asked to shelter in place and isolate because there was a pandemic and there was a concern of spread of disease for people who didn't have a door to close and a place to go into, that was very challenging. If you have COVID and you're unsheltered, you can't isolate in a room because you don't actually have a room. So having shelter really makes a huge difference there, not only for you, but also for public health and public safety if it's a contagious disease. We have learned during COVID that we have fewer people who come to us in need of specifically respite care when we're hoteling rather than hosting overnight shelter that closes up in the morning because we already naturally have that available to them. Those people who would be in need of it are already having that isolation that they need immediately because of the type of shelter we are currently providing. At present, we have had about 200 staying with us in hotel-based shelter rather than congregate shelter to provide for COVID safety. Another fact that we've learned within there is that we have had about 1/5 of the normal numbers of incidents of mental health crises that when our clients have a closed door, they do not have, whereas if they are all in the same space, they've had past trauma and they have a trauma trigger and they're next to another person who's also having a trauma trigger, their chance of that escalating is much higher than when they have their own space to heal and get better. We continue to help. That's what we do. We shelter. 397 families and individuals were served by DuPage Pads through emergency shelter since COVID began. The majority of those were families with stories very similar to Jordan's. Again, 89 children that's at our high point. That's about 1/3 of our shelter population. Oftentimes, they are people who are health vulnerable. They may have mobility issues, and an awful lot of them are parents. About 15% are women fleeing domestic violence, which, as we all know, can lead to health issues of their own right. Another thing we will do, we will continue working together on vaccinations. Thanks to our network of health providers, DuPage Pads is hosting vaccinations in April, May, June, and July, not just for our clients, but for our referral partners. We started our first round yesterday and are so grateful to the DuPage County Health Department for coming out, helping out with that. And we have other healthcare friends who are going to be helping us in the next couple months. We're all in this together, so it's important for us to work together to get more people vaccinated in our community and for them to be safer. We also advocate for affordable housing in our area. And Emily's going to talk to you a little bit more about affordable housing in our next presentation. The Economic Policy Institute studied DuPage County in 2018. What they found was that a family needed at least $16,000 only for their housing in DuPage, and to live comfortably, that income is $95,000. So if you're a family living in poverty, that can be very challenging. More affordable housing means that you have a safe place to stay. We also continue to plan for a future where we use what we learned from COVID to make our services stronger. Thanks for your time and for listening.
Thank you so much, April. If we think of secure housing as a form of healthcare, we also need to understand that the way a building is designed can have positive effects on the health of its occupants. We'll now hear from COD Architecture faculty member Emily Basham.
What's good for human health is good for the planet's health. What's good for our planet's health is good for human health. I'm Emily Basham, and I'm an architect and a member of the faculty at College of DuPage. Tonight, I'm talking with you about sustainable architecture and its relationship to healthy environments. So the World Health Organization states that the highest achievable standard of health is a basic human right. And the United Nations states that adequate housing at an affordable cost is also a human right. Well, the excellence in design of buildings can help achieve those human rights while combating global warming and promoting environmental sustainability. Aesthetic pleasing design with natural light and air is part of the solution. So why do buildings matter for the environment? Well, buildings, their construction operations, and the materials produce 40% of the world's carbon dioxide emissions. US is the worst offender. We consume 20% of the world's energy with only 4% of the population. In addition, the building industry produces hundreds of millions of tons of waste and consumes a lot of resources like potable water. Considering that most of us spend 90% of our time indoors, a healthy environment where we live, play, and work is vital. So what is sustainable architecture? Well, it's design that makes efficient use of natural resources, reduces waste, environmental degradation, and protects and enhances people's health. Some of the design, all the design elements and technologies used for sustainability are also applied to any building type, but I'm showing you examples of affordable housing. So this diagram shows a few characteristics of sustainable buildings. There's solar panels on the roof to reduce dependency on fossil fuels, green roofs and rainwater harvesting that keeps stormwater on the site, reduces heat islands, and there are places to grow herbs and vegetables in private gardens and public spaces, and it provides community spaces indoors and out. Here's an example. This is La Casa Norte. It's a mixed-use community center in Humboldt Park. They have a homeless youth drop-in center, a healthcare center, cafe, and food pantry, and that also includes 25 units of permanent housing for people experiencing homelessness. And I want to point out it's an elegant design where a person would enjoy visiting and be proud to call home. Affordable housing design should be built of a quality that improves the neighborhood and lifts people's spirits. So here's a drawing of the building if they slice the building in half, showing some of the characteristics of the sustainability. It's highly insulated with a very tight envelope. It keeps conditioned air from leaking out of the building, and it protects against drafts and winds, and it keeps moisture out. So sustainably designed passive houses require more ventilation than conventional buildings. Since the average American is spending 90% of our lives indoors, indoor air quality is essential for wellness. In fact, outdoor air is cleaner than inside air that we spend most of our lives breathing. So these buildings provide a constant supply of fresh air, which is achieved sustainably and improves indoor air quality. Poorly constructed buildings, on the other hand, that aren't maintained, they allow dust, dirt, debris to enter. They allow mold and mildew to grow and develop. That exacerbates asthma, allergies, and other respiratory conditions. And asthma can affect anyone, of course, but it's strongly associated with poverty. So there's some more of these sustainable characteristics in addition to the HVAC and indoor health quality, like a courtyard with skylight bringing light to this and air to the center of the building, and high efficiency appliances and fixtures. Here's a shot of the La Casa Norte's lobby. It's spacious, it's appealing, beautiful natural light, bright, joyful colors. And sustainable buildings use non-toxic materials as much as possible that have low volatile organic compounds like formaldehyde. We try to keep those out of the building. Here's another example, Casa Querétaro or Casa Q, that's in Pilsen, that has 45 units of affordable apartments. So sustainable design reduces dependence on technology compared to conventional construction. It returns to working with Mother Nature. For example, it's ideal to orient a building so the long axis is aligned east-west, then we can have large windows on the south and the north. And then also you see here, operable windows allowing for natural ventilation. So here's a corridor in Casa Q. They use 75% recycled content in their flooring. And you'll notice that these examples don't use carpeting because that's a indoor air quality issue. You see the generous lights in the shared corridor, the generous windows that allow natural light in and make the residents feel safer and provide a bit of a sound buffer to city noise. These tight, well-insulated construction of sustainable buildings provides an acoustic advantage. So this is Grove City, and this is a slightly different example because this is adaptive reuse, which means using existing buildings and renovating them, remodeling them for new use. So it's great when we can reuse existing quality building instead of demolishing it. It started out in 1927 as a two-story Cadillac showroom. They added 2 stories seamlessly, and now there's 51 affordable apartments. It has a green roof, geothermal heating and cooling. And another benefit to the neighborhood and the tenants is that the ground floor is a community-owned grocery cooperative. Here's a room, and it has, again, you can see the light, the operable windows, lots of bright natural light. You come in at 8 feet high ceilings, and then it pops up to 10 in the living room and the bedrooms to help create a greater sense of spaciousness. Here's an example in Portland, Maine, that uses a lot of the same sustainable characteristics as other examples. But this is why I chose to show this one, because it has this greenhouse and community garden up on the roof. Well, some of my other examples also try to create garden spaces for vegetable gardening for the tenants. But this one is, I thought, particularly interesting because they also have this community kitchen and a community dining room, and a local nonprofit comes in regularly and meets with the residents to teach them about gardening and preparing healthy food on a budget. And so the residents and the surrounding neighborhood can use this community kitchen and dining room, and it helps integrate. It's one of the ways that you can integrate the affordable housing in with the total neighborhood. Well, all the examples I've shown have community spaces that help residents form bonds. Community interaction can help provide an emotional and psychological benefit. It may not be easy to measure, but we've all experienced this social isolation of the pandemic, and we're feeling really strongly, I think many of us do, about how much we need other people in community for our well-being. Well, I've just had a moment to scratch the surface of sustainable design and its impact on health. I want to leave you with this thought. A healthy, sustainable built environment is something that should be provided for everyone. Thank you very much.
Thank you, Emily. We will now turn to the medical aspect of homelessness. The simple ability to open a window can have a huge impact on physical and emotional well-being. Unfortunately, Northwestern Medicine's Dr. Aaron Quarles often sees the negative impact of inadequate shelter in his Chicago emergency room. Dr. Quarles, in an earlier discussion, you used the phrases healthcare is not housing and throwing turkey sandwiches and Tylenol at the issue. I wonder if you could expand on that concept.
Yeah, absolutely. Thank you guys so much for inviting us to this talk. And I was inspired by kind of, listening to you guys, Jordan's story, April's, expertise. Emily is kind of expanding this into, just thinking about the built environment. And I thought, what could I add as an ER doc who is inherently not an expert in homelessness at all to this conversation? And what came up to my mind was, well, quite frankly, I do see the end result in arguably the most expensive, least efficient, noisy, most uncomfortable place, which has some opportunities to do really good work. And I'll try to highlight some of that, but quite frankly, is missing the mark in terms of thinking about the ways in which we as a society need to be impacting and improving upon the care of our individuals in our community, our neighbors experiencing homelessness. We can go to the next slide. So as mentioned, I'm an ER doc. When I signed up for this job, I was super excited about the prospect of saving lives, dealing with gunshot wounds, unfortunately, a thing that we see in society, heart attacks, strokes, all the acute medical crises that present themselves to society. Unfortunately, however, one of the main roles of the emergency department is to capture all those social ills. And one of the major ones being, and I'm speaking from the context of a doc in Chicago, and I know there are differences across the country and across even our region. But one of the main things that we're seeing, particularly downtown, is homelessness. We can advance. We have had numerous examples shared before about how homelessness is a direct bad health outcome. It leads to circulation issues. It is, the idea of, me talking to my patients and saying, why don't you take your medicines? And them saying, doc, I got nowhere to store my medicines. That rings true. That hits close to home. The idea that I come up with this beautiful, wonderful hospitalization plan, but not having a place to send somebody afterwards, I'm not really confident in the success of the healthcare outcome from that plan. And so the reality is, we know homelessness is bad for your health, and we know that it's a problem that's impacting everybody. It's an equity issue. It's impacting Black and brown folks. We know it's a mental health issue, a substance abuse issue. We know that it is an operational and logistics issue for the health system. At Northwestern, one of the things that I got interested in this work because as a frustrated ER doc, I got sick and tired of doing the same thing over and over. I'd get a patient that would come in, day out, and day in and day out. And I'm talking literally hundreds of times a year, the same individuals, and not having a place to go. And I asked my bosses, I asked folks around me, like, how many actual individuals experiencing homelessness do we see at Northwestern? And they couldn't answer. And I think that gets to one of the big questions that I think we can try to illuminate and expand upon over the course of the next few minutes. We can advance. So what else do we know? A point in time study by the Department of Housing and Urban Development in 2017 actually went out and asked individuals in Chicago, hey, unsheltered individuals, where are you going to stay tonight? And if you look at this list, number 4 doesn't seem like a very high number in terms of things, but if you actually stop and think about it, not a single other place on that list really seems to be a place where you may be able to find, professionals, people that can provide resources, real sustainable opportunities to make improvement. I'll point out that this particular survey was done on a very warm night. We know how Chicago and this region of the country gets during cold nights. So I think this is an underestimation, but this is the lived experience. My patients are savvy, are these folks who've been out here on the streets, unsheltered in particular, know how to survive and they know how to take care of themselves. And in many ways, the emergency department is a place in which they often come for respite. We can advance. This also makes it a really good idea why we may think the emergency department is a wonderful place to intervene in homelessness. And I would argue it is. I think there's an opportunity. I think we have a large volume of patients. One thing I skipped mentioning, at that crude estimate of how many patients Northwestern seen over the course of the year, the rough estimate and more recent numbers suggest somewhere between 2,000 and 5,000 over the course of the year, while the number of Chicago's homeless man or point in time count is around 10,000. So theoretically, these are individuals who are unique individuals. We could be seeing anywhere from 20 to 50% of the city's population of homeless individuals, right? And so the idea of capturing folks in this moment with professionals, with resources, seems like a perfect opportunity to be able to nip homelessness in the bud and kind of really get after it. However, there are a lot of issues we can advance. And as mentioned, the current state of what I have to offer my patients, even in an incredibly well-resourced and incredibly well-intentioned, and I really respect the leadership of my organization for making homelessness a key priority that we're focusing on, is Tylenol and turkey sandwiches. There's no value in these visits. They show up to the emergency department, often not wishing to be there, often harmed either physically from infections and the risks of being in the healthcare space, particularly during COVID, or the trauma of having to, if they're, having mental health issues, be sedated and be restrained sometimes. They often leave with no real change in either their medical issue, their mental health issue, or their social issue. On the flip side, for the hospital and for the provider, there's no value either. I'm not getting necessarily, the hospital admin looks at reimbursement, looks at length of stay, looks at rates of hospitalization, looks at the flow. Other patients showing up to the ER don't want to sit, unfortunately, next to somebody who may not smell the best because they haven't had a place to shower that day, right? These kinds of things weave into and that finds itself into our patient complaints and our patient satisfaction issues, which impacts our bottom line, right? And so these things find themselves impacting us and our ability to kind of think about this problem and our desire. But quite frankly, it really does feel as a provider, as a doctor who sees patients who are struggling with the scenario, like all I'm throwing them is Tylenol and turkey sandwiches, hopefully some dignity in between. But I think that's something that I would argue is a major challenge for many of us as well. Even further, the literature demonstrates that we know housing actually is healthy. It's like Cook County Health has demonstrated that we can reduce emergency department visits, we can reduce hospitalizations by significant margins. And those costs can lead to really incredible opportunities to provide care and revenue elsewhere. Right? We can advance to the next slide. So we know that this is improving. Looking at Yale, they just did just a medical respite program, not even a full housing scenario, but they took 12 individuals, identified 12 people, and tried to just place them in a medical respite. We're able to kind of look back at state Medicaid and say, hey, we saved you a couple $1 million. I think this is kind of how the conversation needs to be moving forward. These next several slides, I have 3 of them we can kind of bounce through, but these are examples where hospitals themselves and health plans across the country, even in Chicago, are saying, hey, we need to get into the housing business. We need to be thinking about if housing is not solving itself and we have patients showing up to our doors and we're not being able to provide valuable care and they're returning to our doors at significant cost, maybe we need to be building our own houses. Maybe we need to be thinking about developing our own permanent supportive housing programs that don't exist currently. I think an example of that was University of Illinois' Better Health Through Housing. They took $250,000 from a donation and housed 25 people. The question is, how successful is it? How sustainable is it? Is Northwestern interested in the real estate business? And I don't think it is, quite frankly, or at least I don't think it has enough evidence to prove that that's the case that we should be making. Next slide. So what over the past couple of years, where again, as an expert, what I've been trying, or as a not an expert, what I've been trying to do is learn about this problem. And I've been incredibly overwhelmed and excited to find that, while I know that many of my patients are showing up with housing needs, massive social determinants of health risk, lack of opportunity, I know that there is an entire squad, there's an entire world out there, hundreds of organizations, thousands of individuals who are experts, who really are there to provide these services that, quite frankly, I don't think a ER is really good at. I don't think a hospital necessarily should be the expert at. The problem, however, is how do I find which patient to put into which program? How do I connect the two? How do I make this the overlap of this Venn diagram a little bit more overlapped? Next slide. So there's multiple barriers. I want to highlight a few of them because this is some of the specific stuff I'm working on with some of the research and some of the collaboration I have across the city. But what we find is, whether we're at Northwestern, University of Chicago, Rush, wherever, St. Joe's, whatever place you can imagine, we don't have the same definitions. That's health systems. Add in the role of HUD definitions and the role of other definitions that are community service agencies that are grant funded, that are philanthropically funded, that have to meet certain kinds of definitions. You add this jumble up, and we might be talking about 3 or 4, 5, 6 different people based, 5, 6 different definitions of homelessness, and based on the services in which people could be eligible for. That's a massive problem. So where do I, as a physician, as a healthcare provider, think about even identifying, screening somebody for homelessness, what type of homelessness, let alone documentation? We joke that the medical coding world has an ICD-10 code right now for, cutting your left pinky with an avocado a knife while cooking your dishes on a Tuesday first encounter. Like, I can get that granular with it, but when it comes to homelessness, that granularity ceases to exist. And if we're going to really get serious about trying to understand this problem, I think that granularity is key to understanding. So this is what it looks like. Our patients come in. I have a little bit of information. I know their medical history, maybe. I know maybe even where they've been to other hospitals. I might know from other notes what they have. But what happens is, with the limited information, the limited footprint, the limited view I have, I don't get to break the cycle. I don't get to end this cycle, this revolving door of folks returning to the ED, returning to the health system. Next slide. So we got together and said, hey, we need to come up with, and this is what we're actively working on. We need to step outside of ourselves as Northwestern. We need to step outside of ourselves as a health system and say, we're not the experts. Can we partner with our community agencies? Can we partner with other health systems to really start to disentangle the data and the understanding problem? And key to this has been the development of cross-sector and cross-system relationships, which I'm incredibly proud to be part of. I have some meetings later this week to talk about how we're going to continue to advance some of the work that we're doing. But if you can move forward, if you can imagine from that prior slide, if we could get this information, if I could take every single individual, medicine loves to talk about personalized medicine, but if I could take every single individual and bring them into any health encounter with a true understanding of the nature of their homelessness. Have they been homeless for 6 years? Has it been a recent transient scenario in the context of COVID and they lost their job? These are very different patients to be dealing with, different individuals. What are their complex medical and social needs? What are the community resources near them where they feel comfortable, where they feel trust, that perhaps we can align with to kind of create warm handoffs and partnership? We could maybe figure this out as a collective and move towards the next future slide. Next slide. Something that looks a little bit more like this, a little bit more robust picture of the individual that presents themselves in need, in search of help, in search of an opportunity to kind of stabilize. That's the ideal goal. That's what we need. I think that's one of the big challenges that all health systems across the nation are actually facing, and certainly what we're trying to disentangle here in Chicago. You can advance. And what I'd be honest is, we are reliant upon our community partners to guide us. You guys are the experts. Jordan, you're the expert. We need to learn from you and listen to you, but recognizing that we have massive resources at Northwestern, at the University of Chicago, that we really can come bring to bear to this problem, if only we can start to understand, what's the real number of patients that are showing up? How often are they getting admitted? What are the medical reasons they're here? That question is shockingly challenging for health systems to answer, not to mention, what can we connect to? How do we identify the right patient to refer to the right place, to connect to the right place? So moving forward, the name of the game is really trying to get us to a point of taking all of this stuff that we know inherently and understand, and try to move from throwing Tylenol and turkey sandwiches at this problem, and really trying to say, how can we connect our community services, our patients' needs, our patients' understanding of their own needs, to our ability as health systems to really guide them to a more ideal form of mental and medical health, as well as community and social health. I think we're all here to have that conversation. So that's it. Thanks.
Thank you for sharing, everybody, your remarkable information and insight in this really interconnected nature between health and housing. We have some questions from our audience. Our first question is, are there models of housing that aid persons with mental health challenges to have a higher quality of life?
I can answer that one. So PADS actually has one. It's called permanent supportive housing It's a type of housing that I know is in the city as well. It is funded through HUD primarily. And what we do is, because a mental health issue would be considered a type of disability, what we do is we are the holder of that lease, and they will pay what they're able. And at the same time, we go in and bring in services and connect them with mental health providers in the community. It is a really great way not only to let someone go to move from overnight shelter, which we call interim housing, to a more independent step, but it is also a preventative step so they do not wind up sliding back into homelessness because they don't have enough supports. If you are watching this from the community and you are wondering, how can I help out in a circumstance like this? I would encourage you to advocate within your community for more affordable housing, because there is a price at which we can pay and price that is too much. And oftentimes families and individuals with mental health issues who are in this type of program, they need to be able to afford to live in an apartment. And we've had circumstances where we had somebody ready to go. So to move to whatever that next step is, but there is not an apartment available for them to move into yet. Back up shelters. So it's harder for people to come out of situations like when Dr. Quarles is referring someone to get into a place, it backs up that system. So we really do need more affordable housing in our community for circumstances like that. Great question.
April, can I ask a follow-up question? And anyone really can answer this, but it was prompted based off of what you said. And I was like, it sounds like there's so many layers to this. And I'm like, advocate for more affordable housing. And I have two, all right, because I don't know anything about this really, is like, what are the local barriers to getting more affordable housing, right? Because this is not like you that's what you want. And as a community, I'm like, oh, that makes sense. That's what so what's the barrier there? Why isn't it happening?
So I'm supporting developers when they come into the community with a willingness to invite them in. If someone applies for zoning in your area, please consider if you're on a zoning council or reaching out to your zoning council, telling them that you think this is important. The last person we placed into affordable housing in DuPage was 18 months old. 18 months. And so if you're looking at not in my backyard issues where people are worried about crime or violence, that little girl is 18 months old. She's not going to commit a crime. She just needs a safe place where she can grow and learn. And she will be healthier if her family has their own kitchen and if she has a safe bed of her own.
I want to second that zoning codes are huge. And you've really hit one of the big issues is zoning, as well as, of course, financing has to be affordable. I mean, developers need financing, whether it's tax credits or something, so that they can afford to build these and maintain them. Maintenance is hugely important, because we've seen failures in the past because something was built and then everybody left. So we got to change the zoning, get rid of not in my backyard, and then funding and maintenance.
If you're looking to be part of a group that does this sort of work, I am a super fan of DuPage United. They are a group of faith leaders and concerned citizens in the DuPage area that look specifically at, this is one of their major platforms, is bringing more affordable housing into DuPage County.
Great. Thank you so much. We have another question from one of our attendees this evening, who wants to know, do school-based programs provide adequate breakfast and lunch options for homeless children? And are there any programs in the summer?
I can take that.
I'm not an education expert. I wouldn't know about that specifically, but I do know that that's exactly the kind of thing that, there's an example in Pennsylvania in particular that took advantage of some local policies that make it completely legal to provide for free and reduced lunch students those meals over the course of the summer at the hospital, right? Like, that's an opportunity where being able to take care some of these local scenarios, and something that I'm not aware of here in Chicago personally. Like, I don't know the answer to that. I'm not the education guy. I'm not the expert in some of that stuff. That'd be a perfect example wherein thinking more creatively about some of the ways in which we can identify these folks in these spaces, and connecting them to those services or establishing what does not exist already could work. I don't know. I'll let you guys kind of jump in on that one. I'm sure you have some experiences.
So previous to this role, I worked at a Chicago-based organization, and I will tell you, in the city, one thing that was difficult for CPS during the beginning of COVID was that worry. Institute had school-based breakfast and lunch hadn't. They getting it to them was a challenge, and so a lot of Chicago schools would try. Like, there were teachers trying to bring food out to their students. And I believe in a lot of the school systems out in DuPage, that is offered as an option, but it is also something that became a little more challenging at points during COVID. What we do, because we're the primary provider of shelter out in DuPage, is we bring meals into our hotel-based shelter. So we have volunteers who come in and they pack up grocery bags, and then those go out on Fridays so that we make sure everyone's fed. And then on Tuesday, Thursday, and Saturday, people bring live meals. So they'll bring more meals out, knock on the door, and say room service, which, again, from a mental health perspective, if you're a child and you've gone through the trauma of homelessness, and later in the trauma of what that means for your parent, and watching that with your parent, feeling like you're staying in a hotel feels warm and welcoming and not scary. And so adding that additional component of room service and a warm meal also adds in to that feeling of safety. And my hope is we'll reduce the chance of trauma triggers, because there will have been less trauma for that child during development.
I'm absolutely going to get to the two other questions that are in the Q&A. I will not jump past them, but it does bring up, you brought up some really just phenomenal numbers, April, when you were talking about the pandemic a little bit. And I'm wondering if people are responding to the concrete quantitative evidence that you now have that says, when we provide this, here's all these benefits. You have right? It's because sometimes people think it's anecdotal and whatever, and they just are very easily dismissive, I guess, of expertise that you 100% know. And now you've had this really awful pandemic, but that has also provided quantitative data that says this works.
Yes.
And are people responding to that?
There was an article in the Tribune that came out last week about how effective this sort of model is in terms of people's well-being, but also their health care. Because if you're a doctor and you've been traveling to try and do medicine for people who are unsheltered, the fact that they're in the same place is great, because you know if they need follow-up care, where to go to help them. But they also, just if you have an open wound and you're unsheltered and it's dirty, that is not safe. There is nothing good about those circumstances. And if you have your own space and a closed door, it is much safer and better for your well-being. I will tell you, DuPage PADS has a medical respite program. Dr. Quarles mentioned this is an effective way of helping people. It's also an effective way for us to begin doing intake for people who are struggling with issues around having a safe place to stay and wound up seeing the worst of that. And it allowed us to move very quickly into hotel-based shelter when COVID hit and we needed to isolate for safety. We were able to do it very quickly because we already had those relationships. And then from a health and safety standpoint, we've had 0 outbreaks. We have cases where somebody has either been exposed, or we've had some folks who've had COVID, but we've had literally, knock on some wood, but we've had 0 outbreaks because a door allows for that safety. A door allows to make sure that we're not having what could turn into a larger contagion situation. And we've watched places on the West Coast where they continued congregate shelter in large numbers because they didn't feel there was another option available. And they had 40, 80, 90 people exposed. That can kill people. That is very dangerous. And what we were able to do provided a great degree of safety.
Yeah, no, I totally agree. The example in Chicago during the height of COVID in particular, I think is an incredible example. There was numerous attempt to find hotel-based housing for folks, or at least kind of like temporary shelter for some of those situations, often led by health industries. Lawndale Christian Health Care was incredibly effective in being able to kind of be an ally and partner for that. One of the wonderful things about kind of jumping into this space and trying to break down some of the walls between our health systems from, across the way, going to the west side and south side and talking to our partners, was we were able to kind of come together and collaborate and create what was called a charge, which is a self-contained group, really to fight and think about what can we do when a safe haven is going to be designated as the COVID positive site. And, Pacific Guard Mission is going to be limited in their testing capabilities, and really kind of thinking, what do we need to do right now? If we had not organically started conversations about trying to improve just the way we screen, identify, and understand homelessness as health systems organically, our ability to tap into that network, get our resources leveraged. So Northwestern was sending testing supplies here. Rush was going out and doing the testing in these places. University of Chicago is coming up and bringing these, without that level of kind of connection and collaboration, we were not able to do any of that. And I think largely saved and prevented unnecessary hospitalizations, especially at a time when that whole McCormick Center congregate shelter thing had restrictions that you couldn't be too sick and you had to have an address. Anyways, that's a whole different conversation. It would have been a perfect place for many of our, while congregates not great, still better than nothing in terms of some of the opportunities in the middle of winter when this was going on. But it just kind of goes to show the value of kind of bringing some of that collaboration and towards the bear, and how we can rely upon each other to be those bolstering supports for our community services that are providing that housing out there. Do it out there better than coming to here. What was necessary, though, was to be able to say, hey, Pacific Guard Mission, we will promise you that any patient you refer to us with any concern for COVID, we will test at a time when testing was scarce. We will guarantee it, because we understand that those patients, the risk to public health of sending that out, if they're going to the wrong location, is massively devastating. Just to kind of add on and add fluff to some of that story.
Another example of collaboration with healthcare that I would be remiss to not mention is we do intake in person. You have to be face to face for someone without a phone and without any resources to be able to come in. There was a point when we could not get those fun little plexiglass guards for safety between us and the people coming in who it was getting cold. And if they did not have we couldn't do outdoor intake anymore. And if they didn't have a place to stay, they could freeze to death. We needed a way to do it. In Northwestern, someone from Northwestern brought out sneeze guards. She drove them to our office. She's watching. Thank you, Anne Marie. So that we could safely bring people in, but we couldn't source them because we were not a medical provider, and that's where they were going. That was the only place that could get them. So it is collaboration, and we're playing well in the same sandbox makes a huge difference.
Yeah, learned a lot from COVID.
No. Dr. Quarles, please.
No, I was just saying we learned a lot from COVID. I think COVID has kind of accelerated these conversations around, all of this level of kind of, hey, we don't have a system right now that says, individual who's intertwined with our health, our community service, our legal system. We don't have a really good way to track and make sure these people are moving forward through these systems, as opposed to just cycling around and kind of getting mixed up. And I think that COVID, while it's been a detriment to many of our lives, many of the industries, and has caused some of the problems that we've foreseen, has illuminated and kind of brought data to bear to this, and has brought a lot of understanding, even emotional human understanding to some of this stuff.
I'm hearing I'm hearing a theme besides the unbelievable significance of stable housing. But I'm also hearing each panelist discuss kind of like these connectivity points, and it started with Jordan talking about like your mom at the dentist, right? And how that creates a connection that opened a door, right? And Emily's talking about the importance of sustaining and talking to housing developers, but also the politics of that, right? And April, like so many connections, Dr. Quarles, you as well. And I'm just curious if there's so many of us watching and are going to watch this later as well. And the community, what role does a community play in this? And what steps besides, like we've talked about a couple of like advocate, what else do we need to be doing if this is a lot about connection?
You know, I can speak to that a little bit. You know, they say, I'm still a firm believer in the saying, it takes a village. And when it comes to homelessness in particular, and I say this so often, a lot of people don't realize that homelessness is real. And what I mean by that is that they feel as though because they never experienced it personally, that there is no connection to them, if that makes any sense. But homelessness is real. Anyone can find themselves in that predicament. Growing up, I never expected myself to be homeless. Neither did my mom, but we found ourselves in that position. So when I say it takes a village, it literally takes everyone to be advocates. You should not have to have an experience yourself in order to, or you don't have to have an experience yourself in order to advocate for something or for someone. We talk about a community. It literally takes all of us coming together to add our voice and to add action to, this conversation. I think April touched on a really good point, even talking about, zoning. It is important to raise your voice and to add to that conversation and all of these conversations regarding equity, housing security, food security, so on and so forth. That list goes on.
One really simple way people can help is by contacting us when they see someone who is experiencing homelessness, because we do have a street outreach program that goes out and engages with people, in the hope is that we can help people sooner so that they do not wind up visiting Dr. Quarles, because that's where it gets more expensive and more difficult. And they have gotten to the point where something that is uncomfortable for them becomes truly dangerous for their health oftentimes. If people who are watching, DuPagePads.org, we have our number to call right at the top. Please always give us a call or drop us an email. If you do, just let us know the intersection so we can come out and help out. Over the long term, I have a dream scenario in which when we do street outreach, we could bring a nurse with, or a medical professional with, or a mental health professional with, again, to diagnose issues early and get to it early before it hits the ER stage. Because I don't think, Dr. Quarles, you guys are hanging around and playing cards in your spare time because you have a bunch of time in ER. It's busy and people are waiting for like life-saving treatment. So if they're not waiting as long, that is better for everyone to have less of a wait time, and ER is less jammed up because people feel like they don't have another option.
Yeah, I'll be quite honest. I mean, when we get some of our regulars, we'll let them hang out in the waiting room for, 9 hours, 10 hours, because I know that they're not sick. I saw them 2 hours ago. I don't have any major liability of that person compared to, ex-cancer patient who's coming in with a really bad fever, right? And so really kind of questionable, like ethically and like frustrating scenarios present themselves when they do meet themselves in the healthcare space, which is why it's not housing, right? And for a variety of like federal regulations like EMTALA, when somebody shows up to the emergency department, they are not allowed to be turned away. Well, what I would advocate is like thinking about, how can we create more creative, ways to advocate and kind of talk to politicians, but thinking about more creative ways in the healthcare space where somebody shows up and says, hey, it's not a medical need, it's a social need. Can I go over to the social ER? Can I go figure out that issue? And that's not an EMTALA violation. The hospital's not, So every patient that comes in, I have to do a physical exam screen. I got to write a note. I got to get vitals. My nurses said resources are insane. I have this friend who's an emergency physician out in Boston. We came to our love and interest in emergency medicine at the same time, partly from our own backgrounds. While, certainly I did not experience homelessness growing up, I experienced a whole host of other things growing up in the inner city of Cleveland. And the reality of it was, the ER, the cool, sexy stuff you see on TV about saving lives, I was really drawn to caring for poverty, right, and inequity. And one of the beautiful things about that is there's so many opportunities, but one of the frustrating things, it's so hard. Having a conversation with my buddy, his name's Dr. Alistair Martin, he was like, Aaron, it's a whack-a-mole thing. This gets back to the question what a community member can do. I'm trying to help homelessness over here, substance abuse over here. I'm trying to deal with, domestic violence over here, immigrant issues over here. Yeah, I can't deal with all this stuff. I got two approaches I think we could use to fix that. One, voting. What if I just got everybody in my ER who's coming to the ER, who's likely to be poor, likely to be Black and brown, likely to be a woman, likely to be a victim of some of these things? Why don't we just get them registered to vote? Because that's the same population of people that aren't registered to vote. Let's get them to have an active voice in their ability to kind of change democracy. I think that's part of it. Number two that I spend a significant portion of my career on is diversity. Just like, quite frankly, I think when we think about the roles in which we're experts and we're at these we're professors and presidents and CEOs of organizations, but quite honestly, like, I have my perspective, and that is a very limited lens and view from which I'm walking into any of the problems that we're facing. Can I find ways to mentor? Can I find ways to reach out to the community? Can I get other young folks with similar backgrounds to me to think about careers in medicine, to think about careers in the service industry? Can I think about not the bottle service industry, like the service industry, like community agencies? How do we really kind of bring a diverse array of folks into the fold? That's a question that I think all of us can be part in. Like making sure that, go tutor a kid in high school. You might get that person to go be the next CEO of an organization that's really making a difference out there. Those are the two things I think are kind of big picture scenarios any individual can do.
I would add on the equity side also, we don't have to wait for people to grow up to have a voice. We could invite people to have a voice on boards now, so we make good decisions. And I think making any effort we can make there is going to be really healthy for an entire community.
Yeah, and I'll add somewhat to what I already spoke about, but support your local nonprofits. And, April mentioned it, in grassroots organizations who are, boots on the ground doing the work. DuPage Pads. I always have to give a shout out to Bridge Communities. Amy Van Polen, I see you in the attendees, list. Support your local nonprofits. It's very important, and they need all of our support. So
I love the positivity, encouragement for action. I also love the idea of April. You're like, here's my dream scenario. I'm like, that sounds like an amazing scenario, right? And we're dreaming big. And I think that the more action that's taken by everybody and everything, and that's what you're encouraging us to do, which is great. There's two more questions about affordable and sustaining housing that I want to touch on. So the question in the Q&A is from the audience, or from our attendees tonight, is: do you think affordable housing should be included within a subdivision, or developers should pay a certain amount to be used elsewhere to support affordable housing? So I think it is a question about incorporating it into subdivisions or elsewhere.
I can speak to, generally speaking, you're going to be talking about multifamily housing, but there's a lot of opportunities for affordable housing in addition to this multifamily housing, like tiny houses or additional, what do they call them, grandma flats type of things that can happen in a more suburban environment. And of course, it's probably not a coincidence that most of the examples I showed were in an urban environment. But so we have to think creatively about how to integrate affordable housing in a suburban environment. But my tendency is to believe that integrating it as much as possible with existing housing is the best way to go about it, because our past experiments with moving it over here in its own little island are failures. And so that's why I wanted to talk about just something like a co-op grocery store that the whole neighborhood uses, or these community kitchens that everybody uses. And some affordable housing even includes a market rate with the affordable housing. So am I direct? The question is integration into existing housing is rather than saying that developers can spend some money to push it over somewhere else. Okay, and suburbs are a little difficult too, because you kind of have to have a car to go everywhere. whereas an ideal development is close to, you could walk to the grocery store or walk to the train or the bus. And so those are some problems with suburbs that affect everybody, not just affordable housing. If I address their question, I kind of went off.
I think that you answered it well, and I saw a lot of nodding from our panelists. So I'm thinking that the nonverbals are some agreements to that idea. You did great. There's one other question in our chat that says, examples of sustainable housing implies or assumes personal responsibility. For example, the gardens and care of the apartments, I think from Emily, from the demonstrations that you provided, do residents meet the expectations or have expectations to pitch in and care for those things?
Do residents feel that? Yes, I mean, the one example I showed was that this nonprofit comes in and it helps people say, they're like, well, I've never grown my own vegetables before. So there's an organization that gets involved and teaches them how to garden on the roof or on the grounds, and teaches them how to cook. And then that gets them involved with the other residents. And some of these community rooms in affordable housing, they get politically active. You know, they start planning their political activism. I mean, it's just like responding to things that April and Aaron and Jordan were talking about. You know, they themselves, I mean, when they're at the point where they need April's help, then they're at a different level. But once you move out of that into affordable housing, you know, it's time for them to roll up their sleeves and they want to control their lives and register to vote and get involved in community action. And in fact, some of the organizations that built, like the one in Pilsen, that was local community members. It took them like 10 years to turn this brownfield into affordable housing. They did it. So it's giving the power back to the people. And so my answer is, well, sure, some people are going to struggle with it, but a lot of people, it's their life and they want to take control of it and become involved with their neighbors and making this planning. So it's already happening that these organizations that are funding some of these, they're already of the neighborhood and the people are involved. So.
You know, along that line, like, you know, kind of transition and analyzing, analogizing, I don't know, I just made up a word there, to the healthcare space or in other social service spaces, right? It may take one visit for me to make a connection with a person, or a social worker to make a connection with a person and be able to get that person on the right path. You know, we have a wonderful clinic at Northwestern called the Transitional Care Clinic, which recognizes that it may take up to 3 years to be able to kind of launch a patient to find their own primary medical home at a federally qualified health center in their own community. So the ability to kind of have a space where you're dedicated to multiple touch points, and particularly when there's a community in that space, potential resources or other experts who are there to kind of help guide and kind of interact or check up on, you know, having a place to go or somewhere somebody expects you to be, sometimes I think really does lead to this ability to kind of start to re-engage in trusting society again, trusting services, trusting agencies again, to really be able to then find your own empowerment and move your life forward. So I think the garden, while, you know, that might be one of those examples, you know, it's right there 24/7 for you to mend, you know, while you're mending yourself.
On the community garden and if you take a look at neighborhood housing services in the west side of Chicago redeveloped a block on Central Park near the Garfield Park Conservatory. They started out with veterans housing and then they started rehabbing other places to get a block together, and they saved a few plots for a community garden, not knowing initially how it would go. And it is the focal point of the neighborhood. It is very much used, so much so that they wound up creating another space, kitty corner, that is a butterfly garden. So there is the vegetable space and there is the floral space that's good for pollinators. Not only is it a good place for people to gather, but it is it's, the police department goes through their regularly and says, hi, it's been a great, like, it's a good way for different community resources to come into what everyone considers to be a safe space. And it has also allowed people to go in and you can get free vegetables. And when you have vegetables to try and cook, and you can try out new things without, spending $8 and maybe your child won't like it, you'll try it out. And maybe you'll develop more habits of eating more things that are higher in fiber and higher in nutrients that your child will like later on in life because they were exposed to a child. So in my experience, I've seen a lot of good in that model.
Excellent. This concludes, excuse me, our presentation for this evening. Dialogue Over Distance organizers would really like to thank our panelists, Emily Basham, Dr. Aaron Robert Quarles, April Redzik, and Jordan Holliday for sharing your time and expertise with us this evening. We're grateful for the work being done to end homelessness and provide support and hope for residents in our community. We're also inspired by everything that you've said tonight to help those in need. For all of our audience members, if you want to get involved, here's some ideas on how you can help. Become a mentor, help family transition to permanent housing, join the DuPage County Continuum of Care and help end homelessness, sponsor a teen in need of stability. If you see someone who's unsheltered, as we had mentioned earlier, DuPage PAD's emergency response line is there. And then for more ideas, you can also visit www.cod.edu/experts. Thank you all so much for coming and being a part of this evening. It was so great and uplifting to hear the positive directions and where we can go when we really dream big and have really strong connections with each other. Thank you.
Thank you.
Awesome.